Hello, dear friends. First of all, I would like to thank the organizing committee for inviting me to take part in this conference and for option to present a very interesting and very actual topic, point of care coagulation testing in the daily practice of obstetrics anesthesiologists. I have nothing to disclose. A couple of words about our hospital, Shaare Zedek Medical Center, Jerusalem. It is a multidisciplinary 1,000 beds campus, and our anesthetic department gives peripartum anesthetic management for more of 20,000 labors every year. In our daily practice, we deal with a very specific Orthodox Jew and Muslim population, and we see a lot of interesting cases. Part of them we treat with the use of point-of-care viscoelastic methods. We use TEC, and how I know in the biggest part of my colleague in Israel use TEC. But we will talk about ROTEM too. On this slide, we can see how many papers about the use of TEC and ROTEM were published in the last 20 years. This is a really hot topic in anesthesia, and of course, the hot topic in obstetrics anesthesia. By the way, one of the last publication in this topic, our last publication, the use of the maximum amplitude parameter in TEC for obstetrics anesthesia. This paper was published a couple months ago, and we will talk about this work a little bit later. This is my colleague and my co-authors in this paper. Today, I will try to give short summary of this literature and with my point of view, according to our experience and according to published literature. A little bit of history. Viscoelastic hemostatic assays, point-of-care devices that give us information about 3 steps of coagulation: clot initiation, clot strength, and clot lysis. All this information presented as a numerical data and what is very important in a visual graphical form. We can see on this slide, we can see the curve from this test as well as the numerical results, and we can compare them to the normal range. Original cup and pin viscoelastic hemostatic assays was first described by Harter in 1948 at the University of Heidelberg in Germany. Now we use 2 variants of this technology. TEC, this is a thromboelastography, and ROTEM, rotational thromboelastometry. And of course, in the obstetric setup, to all TEC and ROTEM discussion, we need to add the discussion and data of physiological coagulation change of pregnancy. The first question, why we need viscoelastic test, and what is the difference between traditional coagulation tests like fibrinogen, PT, PTT, and ratio versus viscoelastic test. Traditional tests were originally designed to monitor coagulation factor deficiency, vitamin K antagonist, and heparin therapy. They can't give us information about the wall dynamic process, such as fibrin polymerization and clot lysis. Additional problem of traditional test, the turnaround time is minimum 45 minutes in machine, and even sometime up to 60 minutes inside the laboratory machine. TEC and ROTEM can perform real-time assessment of whole blood coagulation and fibrinolysis. And we will see the first results something around 5 minutes after the start of test. But, and this is very important point, we need to see this result, this test, and this result in real time on our computer in operation room or close to the operation room. In case we are not able to see live results, we will lose all adventures of these tests. And of course, we lost time, minimum 30-35 minutes from the start of the test. On this slide, you can see our setup. I see online going tech in our delivery room, something 10 or 15 meters from our operation room. We need to see the, for example, in this case of a patient with severe PPH, severe bleeding, tech was started at 1:20 a.m. in the middle of the night, and 10 minutes later, I got this picture by WhatsApp from my on-call colleague. I was at home, and we had the option to plan to discuss the result of this tech and to plan the treatment of this patient together. The next question, in which situation can we use viscoelastic methods in the delivery room? We can, in general, we can divide all reasons to two groups. Emergency situation, as suspected coagulopathy as a result of PPH, atonic bleeding, amniotic fluid embolism, placental abruption, HELP syndrome. And the second group, women with any chronic congenital problem or pregnancy-induced coagulopathy. 2 years ago, we presented our retrospective analysis of 2000, a little bit less, patient who underwent tech testing. Something around 50% of all our patients, in general it was 288 patients, 50% of all tech tests were performed due to massive bleeding, and 5 additional groups, such as the patient with gestation thrombocytopenia, ITP, idiopathic thrombocytopenic purpura, toxemia, and suspected of congenital coagulopathy. Here you can see exactly numbers and percent of patient in each group. The primary motivation for conducting the tech test were or tech guided coagulopathy treatment, usually in emergency situation, or additional information for performing of regional anesthesia in the borderline situation. In obstetric situation, 2 different cases with 2 different etiologies for PPH may have a different coagulation status, and as a result of different coagulation status, we must to perform different treatment. For example, and tech can help us. For example, in the first case here, we deal with atonic bleeding. It was atonic bleeding with estimated blood loss something around 2.5 liters, and on the tech we can see a hypercoagulated state. We see a relative high number of MA, and this is signs of hypercoagulated state. The second case, the case with total placental abruption, with almost same estimated blood loss, 2.8 liter. But on the TEG, we see signs of low platelets number, okay? Now we don't know what exactly platelets number we have, but this is 44 millimeter maximum amplitude, usually result of low platelets number, and usually with low fibrinogen level. And treatment was absolutely different. In the first case, we just transfused 5 units PEC cells, and for this coagulopathic state, we transfused 6 units of PEC cells and 4 units FFP and 6 units of platelets. A patient with amniotic fluid embolism-induced coagulopathy, very difficult cases usually for treatment. And we published our experience with tech-guided coagulopathy treatment in 3 peripartum cases of amniotic fluid embolism and 1 additional case of amniotic fluid embolism as a complication of amniocentesis. For all these critical patients, the use of tech-guided treatment was started in operation room and continued in the ICU. TEG and ROTEM can help for differential diagnosis in these cases and, of course, for correction of coagulopathy. Sometimes TEG or ROTEM results give us additional information to make decision to perform regional anesthesia for patients with borderline coagulation status, or to recommend other kinds of analgesia, peripartum analgesia. For example, patient with ITP, this case, for epidural or toxemic patient with low platelets for one-shot spinal for cesarean section. We see more and more publication literature about the option to make this decision according to anamnesia and to TEG or ROTEM results, like TEG or ROTEM coagulopathy treatment. Maybe after a couple years, we will see TEG or ROTEM recommendation for performing of regional anesthesia. The same situation may be in cases with patients with congenital coagulation pathology. For example, patient with Gaucher disease. Gaucher disease is a glycogen storage disease with coagulopathy as a result of low platelets number or low platelets function. And patient with sometimes patient with normal platelets number have a coagulopathy because they also has a low platelets function. For this patient, we can perform TEG immediately in operation room, in delivery room, and if we see normal results, we can perform regional anesthesia for this borderline patient. Or, for example, patient with von Willebrand deficiency per history. We know that during pregnancy, the von Willebrand factor increased almost to 300%, and the patient in the end of pregnancy are healthy. Even before the pregnancy, they have a coagulopathy. And viscoelastic tests give us the option to check exactly what's the coagulation status of this patient in the end of pregnancy, and to make decision about regional anesthesia. Okay, according to this two systematic review, we can use TEC and ROTEM in our OB anesthesia daily practice, but with the understanding that a hypercoagulation state is typical for physiological pregnancy and can be considered normal for this category of patient. For our colleague that use ROTEM, I don't know what exactly you use in your daily practice. In this systematic review and meta-analysis, which was published in 2022, we provide our reference range for ROTEM parameters during pregnancy in the early postpartum period. This is a literature review. We don't use ROTEM, but we perform this review for our colleague that use ROTEM in the daily practice. If you use TEC, and please check this paper, you can take this data as a normal range for the end of pregnancy, and we use these numbers for our understanding what happened with our patient. Until this period, most of us had worked with the first generation of viscoelastic machine. Maybe you know what is ROTEM Delta or TEC 5000. And now we do a switch, we and a lot of our colleagues, we do a switch to the second generation or cartridge-based devices. The TEC 6S and ROTEM Sigma. This machine gives us rapid answer. During 5 or 7 minutes, we can see the start of result. Easy to use and reduced user errors, because for TEC 5000, even minimal moving of table can change the result of this test, but TEC 6 or all cartridge-based devices, they improve this situation. And they also have the potential for multi-channel testing and for patient treatment with any anticoagulants. The good alternative to the first and second generation of viscoelastic hemostatic devices will be this ultrasound-based technology, Hemasonic hemostatic system, Quantra. Okay, if you will check in PubMed, and you can see more and more literature about this test. This device will allow us to get answer even faster, and the using of this machine will be very easy. We can already see studies demonstrated a good correlation between Quantra measurements and the serum fibrinogen level and diagnosis of coagulopathy. Okay, I try to summarize all my presentation, and this is our take-home message. First of all, the use of viscoelastic hemostatic assays is rapidly growing. TEG or ROTEM guided hemotransfusion is a standard of care in the setup of obstetrics bleeding, but we need a real-time approach to the test results. Viscoelastic test as a point of care can help us in different clinical situations, not just for treatment of massive bleeding. but for make decision about different situation. And now we know for sure that we have no problem with validation of these tests, and switch to the second generation type of this machine happened in this period. Next generation will be user-friendly, faster, and with less errors. Thank you for your attention. I will be happy to answer to all your questions now or by email, by WhatsApp. And of course, welcome to Israel. Thank you very much. Thank you.